we'll move on to our next speaker, and it gives me great pleasure to introduce another colleague of mine, Tim Yusuf, who is a consultant radiologist at King's College Hospital. He trained in radiology at King's College, and that's where he developed his love for ultrasound. He has a specialist interest in multiparic ultrasound, especially contrast enhanced ultrasound and elastography, which he has used and researched in that field for many years. He has won numerous national and international prizes, particularly the Young Investigator Award at both the British Medical Ultrasound Society and in Euroson, and he publishes regularly in scientific journals and has multiple book chapters. He's also a regularly invited speaker at ultrasound and interventional conferences worldwide. So it gives me great pleasure in introducing and asking Tim to talk to us on liver contrast enhanced ultrasound, the DGH service setup, and clinical cases interpretation. Thank you very much.
Thank you very much for the introduction, Adrian. Thank you to the invites to the seminar. As I said, I'm a consultant radiologist. I work both at King's College Hospital and the Princess Royal University Hospital. One may be one that you've heard of slightly more than the other, but I hope to paint you a picture about the use of contrast enhanced ultrasound in a DGH with a specific focus on the liver setting. And as my former speaker said, we'd be a fool to think that liver disease is restricted to tertiary centres. It's simply not the case. The burden is rising to such an extent we have to be aware of these techniques. So here's what I was asked to cover within this. So I was asked to cover from baseline ultrasound to contrast enhanced ultrasound. What does it take? In the red is what I interpret this as. This is a what is it and why does it matter? What does it take to change from an organizational viewpoint? Well, I think from a practical perspective, that's how you set up the service, and that's easier to do in some circumstances than others. But I hope to give you some information about what you need to think about. And then also we're going to touch on some guidance, and the bit that everyone enjoys probably the most is seeing the real cases. And I will make an effort to show you some of the liver cases, but also some of the additional extrahepatic uses, and hopefully to get you an idea of why contrast enhanced ultrasound as a whole is a very important modality. Many of you will know King's College Hospital. As Adrian mentioned, my radiological home growing up, and indeed my medical school home growing up. It's a tertiary centre, large, just shy of 1,000 beds, a number of very specialist areas, liver transplant indeed as well, neurosurgery, cardiology, haematology, trauma, and it's an international referral centre close to central London. It's also got probably one of the worst car parking you can imagine. The Princess Royal University Hospital is nice and leafy in the suburbs of Bromley, just on the edge of the M25. It's a true district general hospital, 525 beds, and it's very much focused on acute medicine and acute surgery. There is a large local catchment area because of the location close to Kent, and it's got a generally quite affluent elderly population. So it is very much different to what you see on each site. So from that, what does it take us into contrast enhanced ultrasound, and what is it? That's the first part of our talk today. It's been established for a number of years and started off with cardiologists using agitated saline echocardiography. Of course, that lacked the stability through the pulmonary arteries, and that was a restricting factor to this going any further. But what you can see from that very simple PubMed search on the image, there are almost 60,000 results just from typing in contrast enhanced ultrasound, dating from 1971 to 2023. That's a huge volume. So there is a wealth of data. This is no longer a new technique. This is a technique that is there that we need to bring into our general practice. The licensing was relatively limited, but it's quite broad in the sense of it's a vascular, liver echocardiography, or the breast. Anything really is a vascular system. Anything you can imagine really has blood vessels inside it. So therefore, you are warranted to use it. I would also add to this as well. I always say recently licensed in the States, but actually it's been licensed for some time in the States now, and that includes pediatrics. It's under the name Lumason rather than Sonoview over there. But that's also led to the established clinical practice worldwide. When it initially started, it was done in a slightly different technique. Contrast Enhanced Ultrasound was administered, and then Doppler scanning was performed in a conventional way. And that was used to boost the signal from the portal vein in liver transplants. And it was to check for patency. So you were using what's known as destructive mode. You were bursting the bubbles, trying to get that flare, as opposed to what we do now, which I'll come on to. But obviously, it was taken one step further. Once you can assess vascularity, you can understand you understand already the pathological patterns of things like lesions. Can you then assess the vascularity within the lesion? Well, this is why the physics comes in, and this is my only physics slide, I promise you. There's a difference between the way you imaged in the old days versus the way that it's done now, and that's based on the acoustic pressure that's applied. With high acoustic pressures above 0.2, you cause bubble destruction, and that results in that flare that we saw on the previous images. However, at low mechanical index, the bubble resonates and therefore emits a signal which is nonlinear. Once you cancel out the static signals, you are left with a pure signal from the microbubbles. What that signal provides you is a truly intravascular agent. So it's not excreted by the kidneys, it's not excreted by the liver, it's broken down within the lungs and pulmonary excreted. So in fact, what you're seeing is a blood pool agent, a true measure of vascularity. Now, the first question that anyone answers, and perhaps rightly so actually, and your managers, etc., will ask you, is this safe? Because that's fundamentally what we're all here for, is something that is safe. And this is probably one of the most well-researched contrast medias there is. The adverse reaction rate from this huge study from the Italian group of 23,000 was 0.0086%. Things like itching, nausea, dizziness, headache, hypertension, things that I feel at the start of my general list. So it's not uncommon to see these things. Of course, you have to be aware that there is a potential for anaphylaxis. It is ultimately a drug. And although the rate is much lower than CT or MRI contrast, you need to have that facility available for an anaphylactic reaction. But it's gone one step further than that now, actually. It's quite comfortable to show the safety in adults, but in fact, it's gone to showing the safety in pediatrics. And EFSAM, the European Federation of Society of Ultrasound Medicine and Biology, have issued a statement saying about pediatric practice, saying that actually it is safe, along with many other drugs that are not necessarily licensed in children, things like amoxicillin, salbutamol, paracetamol. These are drugs that there's no real need to do a randomized control trial, but it's deemed safe in adults, and it's considered to be appropriate to use in children. Ultrasound contrast with SonoView is very much the same. And our experience that we published reflects this. Again, a very low reaction rate in pediatrics. The next step beyond that is then checking it in pregnancy. And again, there's been statements released saying that it is safe in pregnancy with small-scale studies already in progress and demonstrating that it does not cross the placenta. But why should you do it? What's the real benefit? And I hope that's not too loud, but it's the real benefit of contrast enhanced ultrasound is that you can see a movie. You don't just see a picture. You get to watch something all the way through. I'm sure every single person on here is a Star Wars fan. It's inevitable. But everyone thinks they know what that poster says. They recognize the features. But do you know word for word? Well, no, you don't, because you haven't looked through every bit that it shows. And that's the difference of a static modality such as CT or MRI versus a dynamic modality of contrast enhanced ultrasound. That video is available for review if anyone wants it later as well. So what's the principles of it? Well, it now means you have overlapping phases of imaging. You do not have a discrete arterial phase, portal phase, and late phase. It is one phase with contrast recirculating because your blood simply doesn't stop flowing. So therefore, you're able to diagnose more effectively. It's also got the additional benefits that conventional ultrasound does. My former speaker again said that cheap, accessible, it's freely, easily learnable, but also when you add in contrast, it's not nephrotoxic. You do not have to check bloods before administering it. You haven't got the risk with gadolinium, which we are only now just finding out about. I mean, I know that there's recent reports of it being deposited lifelong in the bones in pediatric brains. we are only going to find out the effects of this later on. So we still need to be quite judicious about how we use it. And as I said, it's radiation free. How do you do it? Well, I'll keep this relatively brief. The main thing is you need an optimized B mode scan. Contrast enhanced ultrasound shouldn't be considered a standalone modality. It is something that you need to do as an adjunct. So you want to have done your B mode ultrasound first. And this is what I quite like about it. This is your 10 or 15 minutes with the patient to create a diagnosis by what means is necessary within that room. So you need to be able to have a good B mode scan to start with. And therefore, if your B mode is inhibited by things like calcification or gas, you may struggle again with contrast enhanced ultrasound. Almost every modern machine will have a facility to do contrast enhanced ultrasound. I recommend using a split screen mode so that you can both simultaneously visualize your B mode and keep your area of interest in view, whilst also seeing the contrast image. You inject your desired volume and you commence a timer and a video clip. I feel it's very important to keep a video clip. The reason for this is it's quite hard to make a diagnosis in the room, and I don't feel like you should necessarily be forced to make the diagnosis there and then. You have PACS or Sectra-based systems which you can retrieve and you can review. You'd simply not think about looking at a CT live and only reviewing it in the acquisition room. So why should you do it with an ultrasound? You take your time because you are changing a patient's life potentially. After the 60 seconds where you want to check for any evidence of an early washout, you then continue to image intermittently to avoid bubble washout, and you image up to 5 minutes in the liver. It does depend on which organ you're looking at, and the dosages do depend. And although Rocco may not appreciate me saying it, you can use the vial for multiple administrations, because ultrasound equipment has got more sensitive, and you do not need the full vial for every dose. In fact, actually, it makes it more difficult if you use a full vial for every case. So what happens in a DGH? Well, here's some experience from the crew. I think a lot of people can relate to this. This is looking at 2020 to 2022. There is an escalating CT and MRI demand. This is beyond the 2% predicted of imaging increase. The PRU, Princess Royal University Hospital, is a PFI. It's a privately funded initiative. That means that trying to make changes such as building new walls, building a new CT, putting in a new MRI is very difficult. You're sort of left to an extent with what you started with. And everywhere, certainly within London, is very landlocked. Very much this is starting to affect hospitals out of London as well. What we have is one on-site MRI, which is used almost exclusively for inpatient scanning and anything that requires difficulty, such as pediatric scanning, etc. There are 2 on-site CTs. And I would add into here, there is the development of something called faster diagnostic standards. This is very much like the 2-week wait pathway, but on a quicker timeline. There is a need to essentially have a request received and imaged with a diagnosis within 7 days. Now, this slide just shows also comparative to our larger site at Denmark Hill, the King's site, what our volume of imaging is. The orange being the King site and the blue being the Princess Royal site. You can see that there's actually quite a substantial amount done at a smaller site, and that's partially because of things like not having dedicated neuroradiology facilities. You're then congesting a single scanner. And that's very important, particularly in view of MRI. We do 34% of the total volume of MRI for the trust, but at the same time, 62% of that is outsourced. And they are paid for doing the scans at quite a premium, as well as paid for reporting the scans. And that's simply because of lack of NHS availability or resource on the site. So there needs to be a way of controlling this. That is a huge cost. CT is 100% on site. And that's quite difficult as well, because CT will always be a modality for acute imaging. And it should always be a modality. It's rapid, it provides an easy onset. So it's a matter of whether or not people are selective enough when they do it. But it is inevitably congested. Add into that things like CT colons, which are becoming widespread, cardiac CTs, which are widespread, biopsies, which are widespread. These all take much longer than your average CT scan. So you face a problem where you are trying to squeeze things into CT left, right, and center. On average, we do about 25 ultrasounds a day. And this is probably around similar to the average across most sites. So how do you take it from here in terms of setting up a service? Well, for me, the way I think about this is like a chair. You need a certain number of legs to stand on. And if you're missing one of these, you'll struggle. And these translate into particular challenges. You need at the start, you need the resource, whether that be the ultrasound equipment, the software, the SonoView. You also need the time, and you need the trust of those around you to do it. Ultimately, and particularly in radiology, you require the referrals from other clinicians. You require the trust to do these procedures. And then you build the experience. Once you have that, you have a stable footing. And these challenges to me translate into the following: cost, clinical time, and familiarity. And I'll try to address each one in turn. I put cost at the top because I feel like in the NHS particularly, this is a huge factor. We are constantly looking to cut costs because we are providing what I feel is a quite exemplary service. And I think that in order to do this, we need to make sure it's not the most expensive service on every account. And where we can save money, we should save money. And that's why there are these documents that came through. And these are very relevant. This is the National Institute of Health Research produced a health technology assessment on contrast enhanced ultrasound using SonoView. And they were looking very specifically at focal liver lesions. Now, it's only good to use this modality if it's a useful modality. The first thing to pay attention to is that they looked at incidentally discovered focal liver lesions, screening in colorectal mets, and screening for surveillance of chronic liver disease, and whether or not it was cost effective. But most importantly, in each case, contrast enhanced ultrasound was as effective as CT or MRI. Whilst the cost may be different, it was ultimately as clinically effective. Now that's the critical thing to bear in mind, because that builds the foundation. That is where the trust aspect of this comes in. But then you take it further. Actually, it was very cost effective. It was cost effective, most cost effective in incidental focal liver lesions, but also very much so in surveillance of chronic liver disease. And as we heard, that's a rising burden. Furthermore, we looked at our experience in pediatrics. And again, we saved significant money by doing contrast enhanced ultrasound, particularly when you compare the cost. And these were American costs converted at the time for AJR. But you can see that value is actually escalated. And then you bear in mind that you can use multiple vials. You can use a vial multiple times. So you are not using a single vial per patient. Your cost then reduces further. Bear in mind that the software has reduced in price. Ultrasound machines are already available in your trust. There's no doubt that this may require some expenditure of money because you ultimately need to fund the software and you need to fund the SonoView until it's on your pharmacy. It's unlikely to require a business case due to the small volumes you'll need, but it may well do so. It's a very, very strong business case. You have something from NICE telling you this is the most effective. This is an effective modality, and it is cost effective. So the next thing I want to say is a challenge: clinical time. And that top picture there, picture of a cannula, is what scares everybody. Everyone gets quite worried because ultrasound lists, as I mentioned, 25 a day is what you run at. So generally quite congested lists. Everyone has the fear: what if I have to stop the list and cannulate? I don't have time to do that. And it is viable. We are all inevitably busy. But it needs to be thought about from a wider perspective. Think about your average scan. Someone may go and require, let's say they require GA or sedation in a pediatric patient. That's a significant volume of time. I've purposely chosen that liver image with a Primavist delayed MRI phase. And that's because that says 20-minute delayed. You are in the scanner for 20 minutes, just waiting for that after the injection, after you've got them on the table, after you've done checklist, after you've done your acquisitions of T1s, T2s, etc. So you need to be confident in what you are doing, that you can produce that diagnosis in less time. And that's why the cannulation is not actually as much of an issue as people think, particularly if you're talking about dealing with inpatients, and particularly if you can structure a route of cannulation prior to coming to you. Some of the things that we looked at that we've now instituted to help us are things like twin room scanning. So you have contemporary scanning where people can come, or sonographers in my case, or radiologists can come to me and say, I'd like you to do a contrast ultrasound on this patient. Because our department is set up in such a way that we're able to simply walk into each other's rooms. And I think that's something that needs to be offered. And actually, one of the things I often say is, let me come to your room, because now all the machines are enabled. I will inject the contrast for you. I will do the cannula for you in order to provide you that autonomy and that ability to upskill. So you can also recruit help with cannulation. I tend to find that juniors are very keen to come and watch. As particularly if you plan a list. So in order to maximize your vials, you want to line your patients up, do 2 or 3, 3 or 4, 6 to 10 in a list. And that way you can maximize your use of the contrast, reduce your cost, and you also build up a routine, which, as with anything, builds up speed. There's also the consideration of timing with other examinations. A patient may be coming down for a contrast MRI of their head. You can then time that at the same time with their contrast ultrasound, and you can leave the cannula in. It takes away that step and that fit. But also, what about the wider picture? Well, let's say you discover an incidental focal liver lesion. That then stimulates a cancer referral based on your B mode ultrasound. That then goes to the hepatology clinic. They require a diagnostic, a CT or an MR. Now, bear in mind, each step of this, the patient has left and has reattended. That diagnostic may or may not go to an MDT, or the result may come back to clinic. Either way, it ends in the clinic, hopefully with the patient in front of you or on the phone. You then are able to tell them this is benign or this is malignant. If it's benign, you plan to discharge. Factor in contrast enhanced ultrasound. In the room, you are able to say benign or malignant. In the room, you are able to say this is then something which can be discharged or does need to stimulate a cancer referral. What's the length of time? 2 weeks versus 10 minutes. It's a huge difference. Bear in mind, the other thing that you've lost here is the patient, because you've lost, the patient's gone away, and I can assure you certainly that all patients ever worry about is that they have cancer, particularly if they've had something found on a scan. So during that 2 weeks, they've had several visits, each with its own expense, but also building a patient anxiety, when actually we can say, this is a hemangioma, don't worry, you can go home. This is a hemorrhagic cyst, don't worry, go home. And that's the cost of 10 minutes versus 2 weeks. So your hospitals will thank you for doing contrast enhanced ultrasound. The next step is familiarity. And there's a difference between knowledge and experience, and that difference is connecting the dots, being able to turn something from a pattern to something tangible, something useful. And the truth is, to build familiarity to start with, you may need to play snap. You may need to be doing contrast ultrasounds as well as an MRI, as well as a CT. There is a learning curve. And if anyone thinks that CT or MR of the liver wasn't a learning curve, they're kidding themselves. There was a learning curve. It just happens to be so long ago that we didn't really think about it. But it is essential to do it, because this, as you'll hear me say later on, contrast enhanced ultrasound will be an inevitability. And you can also build your confidence through the guidelines. You know that the guidelines are there. SonoView has been incorporated into NICE guidelines, so the National Institute for Health and Clinical Excellence. And this is our go-to in the NHS. It's maybe not as widely known about as it should be, but it figures directly from the health technology assessment, which is that contrast enhanced ultrasound is recommended for instantly detected focal liver lesions in adults in whom an unenhanced ultrasound is not conclusive. So that's pretty much most incidentally discovered focal liver lesions. And that, if you look at that wording, that's very strong wording. That should be considered. It is recommended. It's an absolute. Very much so, it's also recommended for those 3 patient groups that we suggested. So for potential liver metastases, and also for characterizing focal liver lesions in those with chronic liver disease. And it is considered, this recommendation considers it alongside CT and MRI. And that's on the basis of what we know from the health technology assessment. I've also put in this as well. Many of you may have heard of CEUS LORAD. It's from the American College of Radiologists. This is now their standard speak for describing liver lesions. And there's a CT and MRI version, but they also brought out a contrast enhanced ultrasound version, categorizing 1 to 5, 1 being benign, 5 being malignant. The fact that they've brought it out shows an extreme confidence in its use, and rightly so, given the licensing, given what we've heard about so far. EFSM, I've mentioned EFSM before, have got these freely downloadable guidelines, which I very strongly recommend. And if you look closely, one of our moderators on here is also on the hepatic guidelines, which I'm sure would be happy for me to mention. These are excellent guidelines, and they really do detail everything you need to know about contrast enhanced ultrasound, both in the liver and outside the liver. And they show very much how to do it, as well as what you need to look for in each lesion. So how do you build up this familiarity? Well, you're doing the right thing already. You're in your courses and webinars, your lectures, simultaneous exams. As I said, you'll need to play SNAP initially. You may need to think about a minimum number you'd like to do a year, and maybe thinking about if there are other sites you need to go to get that experience or be mentored. The other thing I would suggest is familiarity needs to be across the board. Within the radiology department, it's one thing, but actually what you want to do is you want your clinicians that you're referring to be familiar with this. So I spent a long time showing contrast enhanced ultrasound images in an MDT, and I reconstructed CT or MRs to make the contrast enhanced ultrasound image and the CT image look the same and demonstrate how much clearer things are. And you should bear in mind that you are comparing contrast enhanced ultrasound should be compared to contrast enhanced CT or contrast enhanced MRI, or B mode ultrasound should be compared to non-contrast CT. That is a comparison. It is not correct to say that a contrast enhanced CT is superior to a non-contrast ultrasound. Of course it wouldn't be, because you're measuring a different thing, you're assessing a different thing. So you have a very different perspective. This is just a brief overview to build some of that familiarity of liver lesions. So you look. This is a standardized chart. You'll find this in many different formats in many different publications, including the ESTM guidelines. You look at your liver lesion first of all on contrast ultrasound. Is it enhancing? Yes or no? Well, things that don't enhance don't have a vascular component. So abscesses have a rim enhancement, yes, but centrally they do not enhance because they contain pus. Cysts similarly don't enhance. If it does enhance, you need to look at your arterial phase, which is your early aspect, versus your portal or late phase. If it's in the arterial phase, and this is where looking at the videos comes in handy, you have a chance to review that. You look at the type of vascularity it has. Is it hypervascular? Is it hypovascular? Does it have a very characteristic peripheral nodular enhancement? Does it have a central filling artery? Well, this is all based on the pathology of the lesion. A hemangioma does not look different on a CT, MR, and ultrasound because pathologically it's the same. You're still having the same pathology. You're just looking at it with a different contrast medium. So look at the arterial phase, and then look at the late phase. Is there washout? Is it more hypocoating than background liver? If the answer is yes, you think about these lesions. If it's no, you think about these lesions. Of course, there will be a degree of overlap, but broadly speaking, your general rule is, if there is washout, think malignant. If there's not washout, think benign. So you can work it in a backwards pattern. Again, that's why the video and saving the clips will come in handy. Reflecting back to the Peru experience and with specific interest in contrast ultrasound, we now do around 300 a year. So quite a reasonable number considering that we started not too long ago when I joined the trust. It's become quite cost-effective modality. You see there's escalating numbers each year. The reason why these figures are actually come from our business intelligence unit. Bearing in mind, again, you're using a quantity of a vial, you're using a degree of contrast bar for CT and MRI, etc. So they're quite broad speaking figures. But contrast enhanced ultrasound at £37, CT at £60 more expensive, and MRI is £140 more expensive if they are done on site. If they are done off site, you're talking about £300 or £400 more. And that adds up to being around a 40,000 year saving. So that is a dramatic number. And again, that's something to take to your business cases and to your general managers and have them reflect on. I would also point out, at the moment, I can tell you from my role that outsourcing is saturated. It's simply nowhere else to put an MRI scanner. There are no more MRIs or CTs available. We are doing the work of 3 or 4 MRI scanners based on outsourcing. And the CT scanner is running all hours to an extent that we've gone through something like 6 or 7 CT tubes. Bear in mind also the interventional side of it, biopsies and intervention. Instead of doing discontinuous imaging with CT, exposing to dose when you don't have to, you are now doing continuous imaging. That means that you have reduction in your time to do a procedure and reduction in your fluoroscopy suite usage. So what we've done, we've moved from having a single machine, which was limited availability, and there's a query about expense, to having all our ultrasound machines contrast enabled now, and indeed elastography enabled. And that's because of the idea of being able to go into any room and do it any time. So you lose that waiting perspective, and you can do inpatients much more easily. Before there was no contingency, we are training up a consultant to cover my list as well. And there are more people becoming comfortable. There is also a great degree of sonographer interest, which I'd actively encourage. Before we had limited help. Now we have nursing, registrar and consultants. My nursing staff are brilliant and do the cannulation for me before the patient comes in the room. So actually you can have these setups and it is available. So now I'll just briefly run through some case studies for you. I think I'm okay for time, am I? Yeah. So these are all quite interesting cases, I think. This is a chap who came in. You can see the CT scrolling there. He has large volume bilateral pulmonary emboli. On the very last slices of his CT, he was found to have a liver lesion. The patient was very unstable, couldn't move back out of A&E. It was only looked at after he came out of the scanner. And the fear was a subcapsular HCC that would bleed if he was thrombolized. So as a junior registrar, actually, when I did this, I went down and took the ultrasound machine, because ultimately it's portable. They all have wheels, and did a contrast enhanced ultrasound by the bedside, which shows a clear peripheral nodular arterialization of this lesion in keeping with the hemangioma. And the patient was able to be thrombolized there and then without any further risk. He's even nice enough to come back and allow us to demonstrate to other people. HCC, of course, this has to be the next one, the other end of the spectrum. So this was a patient with deranged LFTs, no history of significant liver disease prior to that. And you can see that there is this I hope you can see my pointer, this B mode lesion in the left lobe of the liver. It showed arterialization on contrast enhanced ultrasound. Working backwards though, you can also see this late phase mild washout, which is characteristic of HCC. As you see the arterial phase is coming in now. You can see the complexity of that arterial pattern enhancing quicker than the background liver. You're not seeing a snapshot, you're seeing it in real time. It's also very sensitive because what you can pick up here, that is the portal vein, and that is washout inside the portal vein. So this was Lyrad's TIV tumor in vein. So this is diagnostic of HCC with portal venous malignant thrombus. I found this a very interesting case came up in a urology MDT. A patient with known prostate cancer who presented with a liver lesion, but actually it was stable for 2 years, no increase in lesions, no other disease, entirely stable, entirely unaffected. So I wasn't entirely happy this was considered to be a hemangioma. I asked them to have a contrast enhanced ultrasound. The arterial phase, you can see on the B mode imaging. Again, you can see that there's steatosis of the liver, this occult liver disease. It's hyper enhancing. And if you watch just to the end, 25 seconds, you can see so far we are, you can start to see there is going to be early washout. That early washout is characteristic of metastatic disease rather than the late mild washout that you see on on HCCs. And you can see as time goes on, it becomes progressively deeper and deeper and more noticeable. Again, a steatotic liver. Every lesion becomes a question on steatotic liver really now, doesn't it? And it should be. So you need to characterize it. So this is an example where you can use a burst function where you can cause a sudden flash, increase the MI, and then result in the refilling, replenishment of the contrast. And this is useful because you can see the central filling pattern on this lesion. You can see it's centrally filling as a star, and it remains hyper-enhancing, consistent with an FNH, focal nodular hyperplasia, a benign lesion. And here's just another example where you can see that slightly better. Again, an isoechoic lesion here on the background of a normal liver. But watch the tightness of the bubbles, the degree of accuracy you can get of tracking single microbubbles, which are approximately the size of a red blood cell. So you were getting a really detailed picture from this ultrasound, more so than you can with any other modality because the spatial resolution is simply better. This is something else, and this is going to allude to a point I made earlier. A focal liver lesion, again, hypoechoic on a background of a steatotic liver. But what does it do? It enhances the same as the liver in all phases. It does not wash out. This is focal fatty sparing, or a so-called pseudo lesion. Now let me take you back to this slide and reflect on this. That could have taken 2 weeks to get to that diagnosis. That could have been extreme patient anxiety. It could have been delayed, say something happened, say the CT scanner broke, the usual problems. Instead, you can do a contrast enhanced ultrasound in the room, which is what we did, and we were able to discharge them without even reaching the hepatology team. So I think this is a true reflection of where this is useful, and particularly because one of our colleagues in Italy did this study where they looked at benign focal liver lesions and a cost-based analysis. Out of their 400 odd patients, around 40% were the so-called pseudo lesions, the focal fatty infiltration or sparing. These can all be spared in MRI or CT. Looking at, this is a generally unwell patient. This was our typical DGH patient. Generally unwell, no clear cause, no clear identification of what was wrong. Had a liver scan as they normally do. And what you can see is this B mode lesion, which shows peripheral rim arterialization, but no central infilling with this honeycomb appearance, very much in keeping with the liver abscess. They then went on to have a CT scan, but actually you can characterize that on its own and indeed perform intervention on it if needed using the contrast ultrasound. Branching slightly into the other hepatobiliary organs, this is an interesting case. It was someone who presented with minor trauma to the left upper quadrant and was initially thought to be splenic hematoma, but actually what there was this enhancing lesion. And the reason I want to put this in is because if you look at the ultrasound, the B mode, the hypoechoic fluid appearing section looks to be the peripheral element, whereas the solid part was centrally. And I was asked to take 15 core biopsies of this lesion in order to identify it. And I was told, you must take 15 because it's necrotic. So because I have more things to do with my day than that, I decided that I would only take 5, but I promised them I would take only the viable tissue, and they said it was impossible. So I performed contrast enhanced ultrasound and biopsied on contrast enhanced ultrasound, 3 cores, and they said it was the most tissue they've had from this type of patient, which is a splenic angiosarcoma. It's also, I've mentioned a truly intravascular agent. This is a truly intraluminal agent, son of you, because if you inject it into a tube, it will only stay within that tube. Now, on the case on the left, which is running now, you can see parenchymal enhancement when we injected ultrasound contrast through the indwelling biliary drain. The reason for that was because there was a biliary arterial fistula. So if you see enhancement of another structure, there is a connection to it. Compared to the other video, which you can see, where you can see just the biliary ducts lighting up. Very late, you can see 1 or 2 extravasation of bubbles where it has reflux into the portal vein, but you can see just the biliary ducts. And this is as good as a cholangiogram. Indeed, you start to think about possibilities with things like 3D imaging. Moving slightly out of the liver, I want to show you a few other cases because I think that this can also help your case for building contrast enhanced ultrasound in your practice. Simply because you have a liver patient doesn't mean their only pathology is from the liver. There can be many different causes, and usually they are comorbid from a number of other reasons. This was a patient who had multiple collections within the abdomen. We injected ultrasound contrast through the gastrostomy tube to check to see its patency. And yes, it filled the stomach. However, you can also see, and only on contrast ultrasound can you see, this thin line tracking along the surface of the peritoneum. And that led to the collections within the abdomen. And once we took the gastrostomy tube out, you can see a pinhole perforation within it. This is an example of a trauma, and I show this because of the MDT reference of showing cases which make people familiar. This was a young lad, a 3-year-old, who had a weight dropped on his abdomen. He then looked like he'd transected his left renal artery and had completely devascularized his kidney. Actually, he hadn't. He had cortical necrosis, but medullary preservation. And you can see that on the contrast ultrasound. He subsequently went on to have an MRI, but the MRI showed exactly what the contrast enhanced ultrasound did, but without the need for a general anesthetic, without the need for gadolinium. And that's the sort of image you can put across in MDTs to show a representative. This is another renal trauma. Again, you can use it for liver trauma, splenic trauma, anything really, but particularly in the follow-up. And here's an example. That kidney looks abnormal, but it doesn't define to you quite how abnormal it is until you give the contrast and you see the devascularized plane and the subcapsular hematoma. The laceration goes indeed right the way through the kidney into the renal hilum, which you can't appreciate on B-mode ultrasound. And again, you've got the opportunity to spare the dose during follow-up. If you have a pseudoaneurysm within there, it becomes very obvious. It's very clear to see because it's continually arterially enhancing. So it's not like you're losing it because the phase washes out. The arteries still remain the arteries. This was it's probably one of the only cases I've seen like this. It's a renal cyst. It was deemed a Bosniak 2F because of thin enhancing septations, meaning a minimal risk of malignancy, but requires follow-up. 6 months later, the size has not changed. And I can tell you the CT appearances would not have changed. But on the contrast enhanced ultrasound, it is significantly more solid. That solid appearance means it has transformed into a malignancy, and such a small lesion, that's the first time I've seen that. Looking at a lung, I was asked to drain a pleural effusion. There's a query of whether or not there could be any pleural disease from a previous malignancy. You can't see it on the B-mode ultrasound because of the artifacts, but actually you can see very clearly an enhancing lesion, which could be potentially catastrophic should you go through that with your drain. One of the places in the body where you simply can't image by many other means is testes. And if you have these two images of intratesticular lesions, you're very hard pushed to say which one is malignancy and which one isn't. Contrast enhanced ultrasound tells you clearly one enhances and one doesn't. The hematoma does not enhance at all. The seminoma, the malignant tumor, does enhance. And you can see those sorts of appearance again in this patient who had lymphoma, developed a paratesticular lesion, and is asked, what is it? Again, B-mode, you'd be very, very hard pushed to say that this is benign. It shows no enhancement at all. And this is, I quite like these images where you can build up your contrast over time and get almost angiographic-like images. And you can see clearly there's no central filling. So I'll just summarize briefly what we've said now, and I hope you've enjoyed seeing some of those cases. Contrast enhanced ultrasound is ultimately all the things that my former speaker was asking for. It is useful, it is cost effective, it is accessible. There is a learning curve, yes, but there is a learning curve for everything, and once it is there, it will be there to stay. It offers solutions, and what I want you to appreciate from that picture maybe is that it reframes how you see things. It isn't ultrasound can only do this, ultrasound can only do that. It's ultrasound gives you a possibility. It gives you a chance to be able to diagnose someone before they leave the department, to be helpful in stratifying who needs to go further. It has got ever increasing popularity, and the last line I'd leave you with is that it is an inevitability. This has to come in the same way that elastography is being used, contrast is being used, B mode has increased, things like microvascular imaging have come to a forefront. This is something that will be being done more and more. And it just simply has to be done in places like the DGHs. It can't be restricted to tertiary centres alone. And my feeling is that this is very truly an inevitability. Thank you very much for listening. I hope you appreciate it.
Thank you very much, Tim, for the really elegant presentation showing the versatility of contrast ultrasound, and also the strong case for it to be adopted everywhere in our clinical practice. There's no burning questions except one comment about and what an amazing presentation it was by one of the speakers. So thank you very much for that.